Welcome to our webinar on pain management opportunities and challenges. My name is Ben Knoll. I'm the Director of Patient-Centered Research for the Global Healthy Living Foundation and CreakyJoints, and also the co-principal investigator for Arthritis Power, Patient-Powered Research Network, Patient Research Registry. In these webinars, we're highlighting issues of importance to patients, and this one is a particularly hot topic in this current climate. Pain management, of course, is really important to deal with a lot of the conditions that we see within our network. And there's also increased scrutiny of the use of opioid pain medications. So for that reason, we thought it would be important to hear from an expert in this field and talk about what some of the controversies are and where they come from. So we're joined by Dr. Will Becker. He is a general internist, both a clinical doctor and a researcher. And he has expertise in clinical epidemiology, addiction medicine, and pain management. And his research, educational, and clinical efforts broadly aim to improve the quality of chronic pain treatment in general medical settings, especially in the complex overlap of chronic pain and opioid use disorder. He directs the Opioid Reassessment Clinic at the Veterans Administration Connecticut Healthcare System, and he also leads several research projects through the VA, or the Veterans Administration, also projects funded by NIH, the National Institutes of Health, PCORI, the Patient-Centered Outcomes Research Institute, and also the FDA, the Food and Drug Administration. We are delighted and grateful to be joined by Dr. Becker to hear his expertise. So with that, I'll turn it over. Thank you very much and welcome, Dr. Becker.
Sure, my pleasure. Thanks. So yes, I'm going to be talking about pain management opportunities and challenges, and I just want to underscore that I come at this topic. I was trained as a primary care physician in the early 2000s was when I did my residency, and was seeing a lot of patients in my clinical practice who had chronic pain, some from rheumatic conditions, some from other sorts of pain-generating conditions, and was finding that I was not well trained in medical school on how to deal with pain, and also not getting much additional training in my residency, and set out to, I guess, in essence, teach myself or to reach out for opportunities to learn more. And it's become pretty clear since that time, this is not an unusual experience, that medical training in the treatment of chronic pain is pretty sparse. And so I've kind of made it my overall career goal from clinical and research standpoint, to learn more and to contribute to some of the ways that we can improve our management of chronic pain. So that's what we'll be delving into.
Will, can I interrupt for just a second?
Sure.
Sorry to bother. We're a little bit about hearing you. It's cutting in and out. So I wonder, are you on a headset or calling in on the computer?
No, I'm on my cell phone with a.
All right, so I'll cut through my intro there since it was getting broken up. So this is a definition of pain that comes from International Association for the Study of Pain in 1979. But I'd like to lead with it because it is still so true today. Pain is an unpleasant sensory and emotional experience associated with actual potential tissue damage or described in terms of such damage. And what is important here is that always pain is both a sensory and emotional experience. I think especially in the biomedical model, which is sort of the old model in pain management, we would talk about, you know, um, this disconnect, that some pain was real, some pain was not real, some pain was in your head, some pain was uh, that's sort of gone by the wayside. It's really that always there's the the sensory experience and the emotion that's attached to it. I think that's important to consider as we think about treatment. So I'm going to spend one slide talking about pathophysiology of what we have learned about chronic pain over the past 10 to 20 years. And this is a schematic of the peripheral nervous system on the left, the dorsal horn of the spinal cord in the middle, and then the central nervous system on the right. And essentially the process as we understand it is that there is tissue injury, and that's exhibited on the left-hand side with the TNF-alpha, the IL-1, and so on. These are chemokines that irritate the nervous system, and they cause an ascending pain signal to go up the pain-transmitting C fibers that synapse in the dorsal horn of the spinal cord, and then cause further ascending pain signals up into the brain. And that's where pain is perceived. And you can see also in the green, there are some descending pain inhibitory signals that actually help dampen the ascending pain signals going up to the brain. So what have we learned about this process? So two concepts that I'll mention: neuronal plasticity, and that is that peripheral nerve injury that we spoke about in the previous slide causes recruitment of macrophages and glial cells. These are inflammatory cells. And this inflammatory process causes dysregulated nerve regeneration of both the A beta and the C fibers that we saw in the previous slide. So the inflammation itself actually creates nerve growth. And those overgrowth of nerves populate the dorsal horn of the spinal cord, causing the next process, which is central sensitization. Excess of the A beta and the C fibers in the dorsal horn lead to compensatory changes to the NMDA receptors that are in the dorsal horn that lead to lowered pain thresholds. And so what does this all mean? It means that as a result of these processes, pain stimuli that used to be only mildly noxious can become intensely noxious. That's called hyperalgesia. Or pain or stimuli that weren't even noxious at all to begin with now become noxious, and that's called allodynia. So I'll hear patients say, just even sometimes putting the bed sheets over my feet can cause pain. That's a classic example of allodynia. And this pathophysiology explains how an injury that could have happened years ago might still be causing pain today, or even something like out of control diabetes, which causes inflammation and injury to the peripheral nervous system, can cause ongoing chronic pain. But besides what we've learned about what's going on at the tissue level with these chemokines that I referred to, what we've become to appreciate more and more in terms of the complexity of chronic pain has to do with the layers of this onion that I'm showing you. At the base, there is the tissue damage that we just spoke about, but that begets pain sensations, which begets thoughts like I'm damaged or disabled, that begets emotions like fear or grief, which lead to suffering, which lead to pain behaviors, which is the outward expression that an individual with pain exhibits, demonstrating that they are experiencing pain. And so in the biomedical model that I referenced, the old model, we would focus on the tissue damage or we'd focus on the pain behaviors, and we would ignore these inner layers of the onion. And I think it's pretty clear now that if we want to do a good job of treating chronic pain, we can't ignore those inner layers, and we have to address all these processes to do a more effective job. And that's what we'll talk about moving forward. We know chronic pain is markedly ubiquitous and costly. We think that of all adults at any given time, 25% of U.S. adults have chronic pain, 10% of whom have disabling chronic pain that limits work and family activity. We would call that high impact chronic pain. It's the second most common reason for outpatient visits in the U.S., with an annual national economic cost estimated at up to $635 billion. And yet, as I alluded to before, I'm not sure if folks could hear me, but as of 2011, this is somewhat old data, only 5 of the U.S.'s 133 medical schools had a mandatory course on pain. A few more have joined on, but it's become increasingly clear. Our medical system, our medical training system, has not been historically very good at training folks in learning how to manage pain. We're trying to improve that. Luckily, or the good news is, I should say, that there is this vision of what evidence-based, high-value chronic pain care should look like, and this comes from both the Department of Health and Human Services and the Institute of Medicine have, over the last 5 to 10 years, articulated this vision. What are the elements of high quality and high value chronic pain care? And in the middle, you'll see behavioral therapies. These are things like mindfulness-based stress reduction and cognitive behavioral therapy, partnered with physical activation, because we know one of the hallmarks of high impact chronic pain is that people stop moving. They become afraid of movement. And so how do we help patients re-engage with physical activity, structured exercise programs, and then rational pharmacotherapy? And that is medications that people improve and don't make them worse. Those 3 pillars, all in the context of helping patients with their self-efficacy, helping them take charge of chronic pain, as well as their self-management skills. All of that should be done in the setting of promoting overall healthy behaviors, not smoking, using healthy amounts of alcohol, and then addressing comorbidities, both physical and mental. I gave the diabetes example earlier. If a patient has, let's say, uncontrolled diabetes and painful peripheral neuropathy, we know we're not going to get a handle on their pain unless we're able to help them control their diabetes better. And lastly, if this can all be delivered within an integrated health system where the different providers are communicating with each other and are communicating the same philosophy towards pain management, that helps patients do better as well. So this is the vision, and I fully recognize that in many healthcare systems, we're struggling to achieve this vision. In the VA, where I do my clinical care, we're actually having a bit more success because we do have access to many of these therapies. And so oftentimes I'll show this vision and there's skepticism, you know, especially among doctors. So far, the evidence-based non-pharmacologic treatments for chronic pain. Well, it turns out there's quite a few of them, and the evidence base is actually getting stronger by the month with new clinical studies coming out. In terms of physical activation, there's good data supporting structured exercise and physical therapy, emerging data, yoga and Tai Chi, and water therapy or aqua therapy. Behavioral treatment, again, good data supporting cognitive, behavioral, and mindfulness-based stress reduction, and other techniques, sometimes called manual therapies, chiropractic, acupuncture, trigger point injections, and so on. And I think, you know, I think 5, 10 years ago, we would be saying, you know, should we be providing these therapies for our patients? And I think in 2017, the conversation has changed. How do we do it? We definitely should be, but it's how do we make sure available, accessible to patients, and that's one of the challenges we have in front of us. Just recently, Michelle pointed it to me, a systematic review put together by the Agency for Healthcare Research Quality, or AHRQ, talking about non-invasive, non-pharmacological treatment for chronic pain. The website I've listed for you there, and this hasn't been published yet. They put it on their website, and they're asking for public commentary on their findings. So if something that you're interested, I invite you to log on and see. But the purpose of the review to assess the evidence on non-invasive, non-pharmacologic treatments for common chronic pain conditions, and the key message that they summed up: a number of neurological interventions may improve function or pain outcomes 1 month to 1 year after the completion of therapy. Exercise, acupuncture, multidisciplinary rehabilitation, mind, body, and mindfulness practices such as CBT may improve function or pain outcomes for specific chronic conditions. I won't read the rest, but you get the idea that research is emerging, now, you know, becoming more of a question of how do we make these treatments more accessible, because we are finding that they are effective. So to summarize my remarks to this point, chronic pain is a biopsychosocial experience. Our understanding of its pathophysiology is growing, and multimodal treatment, meaning bringing in treatments from those 3 pillars that I talked about earlier that addresses the biopsychosocial experience, is the most effective. So with that, I want to transition to talking about opioid therapy. And just a word on terminology. The proper term is opioid analgesics, which is kind of a mouthful, but that encompasses both, which are the naturally occurring compounds present in opium, both morphine and codeine, and then the opioids, which are manufactured. You have the semi-synthetics, such as hydrocodone, hydromorphone, and oxycodone, as well as the full synthetic products, fentanyl and methadone. And what's become increasingly clear based on data like what I'm showing you here is that there's been fairly marked prescribing of opioids in the US over the past 20 years. Here, the data I'm showing are from 1999 to 2010, opioid sales in red. But what's very, and I think becoming sort of unrefutable in the medical system, is that the similar rises in opioid-related deaths, which we see in green, as well as opioid treatment admissions to facilities for the treatment of opioid addiction, have risen almost in lockstep to opioid prescribing. And it's well accepted now in the medical community that, physician prescribing is what's driving the surges in opioid-related deaths and opioid treatment admissions. But what's perhaps even more concerning to me is that while we've been using more and more opioids, especially in the treatment of chronic pain, the evidence for their long-term benefit is just not there. This is a systematic review from 2010 that looked at randomized trials, non-randomized trials, case series in a variety of pain conditions, looking at outcomes 6 months or longer, finding that despite the identification of almost 5,000 participants, the evidence for the effectiveness of long opioid therapy in chronic non-cancer pain is too sparse to draw firm conclusions. They did find a medium effect size in patients who completed these studies, meaning there was some benefit to opioids among folks who completed these studies, but those were only 30% of the study samples could even complete the studies. 70% were dropping out because of side effect or because the opioids weren't working. But importantly, no long-term studies looked at functional outcomes, which is really a shame because we would be prescribing these medications in hopes that patients would do better functionally. The studies themselves were not addressing this. There have been some studies in the intervening 7 years, but not as many as we would have hoped, given how widespread opioid prescribing is. My colleague Aaron Krebs just completed the first year-long study of opioid therapy in the U.S., and she found that comparing the opioid group to the non-opioid group, that folks on long-term opioid therapy did no better in terms of pain-related function and had twice as many side effects as the non-opioid group. And we've really started to appreciate some of the drawbacks of long-term opioid therapy. For tolerance, and that means higher doses are required to achieve the same analgesic effect over time. There's a high prevalence of tolerance. In fact, in folks who are on longer than 3 months of therapy, we generally expect tolerance to develop. We do know that tolerance does develop to some of the toxic effects of opioids as well. Then there's withdrawal syndrome, which are characteristic symptoms upon abrupt cessation or lowering of the opioid dose. And then this last phenomenon that's only more recently understood, and that's called opioid-induced hyperalgesia. And this is a paradoxical worsening of pain with higher opioid doses taken for extended periods of time. And imagine that our goal, of course, is to help pain, but we're finding that in some cases the pain actually gets worse the longer that the patient is on opioids. And besides, the concerns about lack of benefit and overdose, there are other important toxicities, including constipation, itching, nausea and vomiting, hypogonadism, induced hyperalgesia that we just spoke about, sedation, impaired cognition, falls in motor vehicle accidents, blunted respiratory drive, addiction or opioid use disorder, and then the non-fatal and fatal overdoses that have really plagued this country over the past, at an increasing rate over the past 5 years. What some important research has told us is that the odds of experiencing an overdose with opioids increase in a dose-dependent fashion. So on the left-hand side of this figure, you see dose, in terms of milligrams per day on the left-hand side, and then in 3 studies over the past 5 to 7 years showing that as that daily dose increases, the risk of overdose increases in almost a dose-dependent fashion. So to summarize what we've learned over the recent past about opioids, some important limitations. The central sensitization, that process we talked about that underlies much of chronic pain, may not be responsive to opioids. Chronic pain has a prominent psychological component for everyone, and it's unclear the role of opioids in interacting with that psychological component. Long-term therapy induces tolerance, necessitating higher doses. Yet we know those higher doses chronic increases the risk of opioid-induced hypergeusia and increases the risk of toxicity, both acute and chronic. So with all this concern about, underwhelming effectiveness and a number of different risks, the CDC finally stepped forward in 2016 and developed a guideline for prescribing opioids for chronic pain. I'm sure some of you are aware this guideline came out with a lot of ballyhoo. The CDC, New England Journal met, the New York Times covered it. President Obama taking more steps to address the prescription drug abuse and heroin epidemic. I think sometimes all the kind of press, a lot of the core messages of the guideline get lost. So I really would like to spend just the last minutes of my talk focusing back on what the guidelines say, and focusing on what our next steps should be if we're to follow these guidelines. So these are the top 3 that I want to talk to you all about. That non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred for chronic pain. It doesn't say that opioids need to be taken away or taken off the table, but that non-pharmacologic therapy and non-opioids should be the first line. Clinicians should prescribe the lowest effective dose, should carefully reassess evidence of individual benefits and risks when increasing the dosage to greater than 50 milligrams morphine equivalent per day, and should in general avoid increasing dosage to greater than 90 milligram morphine equivalent per day. And then importantly, if benefits do not outweigh harms of continued opioid therapy, clinicians should optimize other therapies and work with patients to taper to lower dosages or discontinue opioids. Another way to look at this recommendation is if benefits are outweighing harms, if patients are benefiting from opioid therapy, they can be continued. They should be monitored closely, they can be continued. However, if benefits do not outweigh harms, again, patients to optimize other therapies and to lower opioid doses or discontinue them altogether. So we really just scratched the surface here, but I do look forward to discussing these more with you all. The challenges are many. When it comes to non-pharmacologic therapy and non-opioid pharmacologic therapy being preferred for chronic pain, how do we make these therapies available, accessible, and affordable to our patients? Some therapies better than others. Are some better for individuals with specific conditions and characteristics? These are all the next questions that we're trying to tackle in our research. So in terms of the dosing recommendations, how do we train clinicians to do this? How do we monitor adherence with these dose recommendations? And then the last one, if benefits do not outweigh harms of continued opioid therapy, optimizing other therapies and working with patients to taper to lower dosages. How do we motivate patients to want to make a change, even it's very clear that the benefits are not outweighing the harms? But critically important, how do we partner with patients to lower doses safely, effectively? We want to pull the rug out from underneath anyone. We want to do this in a safe way so that patients can gradually come down opioids and perhaps take a new path with their treatment and experience a higher quality. So in view of this call to greater than a slide talking about a study we do have funded by the Patient-Centered Outcomes Research Institute called VOICE, Veteran Pain Care Optimization Improvement Comparative Effectiveness Trial. It's the control trial of integrated pain team versus pharmacist-led telephone care management for patients who are on greater than 50 milligrams morphine equivalent daily dose. And we're essentially saying to folks, you're not entering this trial to have us reduce your opioids. You're entering this trial to experience one of these two care management strategies, either integrated pain team or pharmacist-led telephone care management. In that trial, we will probably recommend that your opioid be lowered, but we want to do so only in the context of providing you other pain treatments, doing so in a partnered fashion. Patients who are on greater than 100 milligrams morphine equivalent daily dose who agree to taper will be secondarily randomized to standard versus plus or expanded taper options. And essentially that expanded taper can be full rotation, which is a medication initially used in the treatment of opioid addiction, but we're finding has good, potentially good benefit for the treatment of, and it's a lot than opioids. So folks in this who are on high dose therapy will be off this randomization to optional rotation to Suboxone. So to summarize, it's clear that we need to move away from opioid-centric chronic pain management. How to make this paradigm shift is one of the biggest challenges facing U.S. medical care. With that, thank you for listening, and I would very much appreciate some on my points and some hey.
Thank you very much for the presentation, Dr. Becker. We have a few questions that have come from the patient audience for this webinar. So we'll address each one in turn, if you don't mind. The first question is about pain across different conditions. So the question is essentially, is pain different depending on the condition? So is there a different process? Does it experience differently, whether it's rheumatoid arthritis or multiple sclerosis?
Yeah. Are there, and also embedded in that question, is the pathophysiology of chronic pain different across different conditions, and especially for somebody who might have multiple pain conditions? You know, of course, for the individual, it is a highly individual, and different kinds of pain generators can have similar in that experience them. But in terms of the way the brain processes pain, we think there's remarkable similarity across various conditions. It has to do with part that I talked about before, this dysregulated nerve regeneration, and central sensation is remarkably consistent across pain.
In the current discourse about opioid use for pain management, there's a lot of encouragement for patients to steer clear of opioids. And many patients often interpret that or hear that as that the doctor or healthcare professionals do not believe that a patient's pain is real or bad enough, or patients may sometimes feel like they're being told that they are an addict. So if we want to modify behavior around pain management and opioid use, there's a real feeling from, I think, the patient community that we need to alter the way we communicate about pain and about the use of opioids. So based on your work, both clinically and in your research, what are your recommendations for how we might go about this?
But I think, you know, especially in the medical profession, there is often in this dialogue, this sort of stigma opioid, long-term opioid therapy, that even patients who are on them and doing well are considered to be addicts, which is unfortunate. I mean, when I teach, I say there's a role for long-term opioid therapy. It benefits some patients, and we need to follow the guideline and, do our due diligence, assess, is this therapy benefiting the patient or is it harming? And what's the trade-off? And so that if they're benefiting the patient, they should continue on. And I think we've made some headway and providers understand that it's the matter of if you're on opioids long term, you have an addiction problem. But I will acknowledge that kind of stigma is still out there.
The third question refers back to your slide about the lack of evidence on the long-term use of opioids for pain management. And you mentioned that there's no good studies on the long-term impact of opioid use on functional outcomes. So this question is about the design of the research. So were these studies based on patient reports of pain, the existing studies that are out there, or are they also based, or are they primarily based on clinical data of disease activity? So I guess the question is around what were the primary outcomes, and it sounds like they were related to pain rather than disease activity or function, but just wanted to confirm that. Can you respond to that?
That's interesting. Yeah, these pain studies are all, the primary outcome is related, and not related to disease activity.
This next question has to do with your explanation of central sensitization, the phenomenon that there's a lower pain threshold as a result of nerve injury. So over time, the same sort of approaches to pain management or medication approaches don't necessarily work the same way with central sensitization. So what are your thoughts on the idea that fibromyalgia pain is not a real condition, or how does fibromyalgia, that condition, relate to this phenomenon of central sensitization, and is there sort of related question is, and which you addressed I think in your presentation, that there seems to be both a physical and sort of psychological, emotional component to pain. But I guess in particular, if you could talk about central sensitization and fibromyalgia in particular.
Yeah, I again words, but I think the judges, central sensitization. We believe that this is the core process that's happening in fibromyalgia, and I think most basic scientists, I'm a clinical scientist, but most basic scientists, and it's 100% real. I mean, we can demonstrate it with MRIs that what's going on with the nerve regeneration and the central sensitization process. I'd say fibromyalgia is sort of like perhaps on the severe end of the central sensitization process, but it is sort of the prototypical example of that. And I think I also acknowledge that there are providers who would doubt, that fibromyalgia is a real condition, but I think that's some old thinking that's out of date.
This is a question about the research that's been conducted in pain management, and it seems like most research or all research on pain has been on patients with a single condition or one very dominant primary condition. So we wondered, are there clinical trials covering people who have multiple pain generating conditions at the same time? So for example, lupus or multiple joint injuries or osteoarthritis. So there's several conditions that all at once may be causing pain.
Is there covering non-pharmacological treatments for people who have multiple pain-generating conditions? And where we stand in the field right now is that there hasn't been a whole lot of research for it's usually that the single pain condition, and the patient gets enrolled in. But the reality is there are a lot of people with multiple pain generators, and we need to know, are there these are more effective for them, or sequencing of therapies. And the short answer is we're not there yet with the research. That I would call that more pragmatic research that fits more real world patient characteristics, and there needs to be more of it, basically.
It seems like there's at least two sort of bigger picture interventions that would help shift us away from relying so much on pain medications that are opioids. And one would be if health plans or insurance companies would be more willing to cover non-pharmacologic treatment for pain. So other interventions that aren't necessarily a drug. So that's one possible sort of intervention. And then the other one is to increase or expand the amount of research, fund more research into non-pharmacologic treatment of pain or approaches to pain management. So I wondered if you think one is easier than the other. Is it easier to increase funding, or is it easier to get insurance companies to change the way they reimburse for treatment of pain management?
this is really the $64 million question, or whatever the figure is. We historically in the U.S. medical system have favored reimbursement of invasive, high cost for pain that haven't been very effective. And we've also favored reimbursement and coverage for opioid analgesics, which also, while they're effective for some, have not been very effective for the majority of people. So there has to be an entire cultural shift from, policymakers down to, local health plans for funding and reimbursing the treatments that do work. And this is a call that's being made. I think the calls are growing. I think the opioid crisis is finally drawing the attention that this issue needs. Is, well, what opioid? Giving people alternatives, and we were making opioids cheap and easy to get, and making it easier for doctors to prescribe opioids about anything else. And so I think it's finally drawing attention that the way we go about treating pain and the sorts of services we reimburse for need to be revolutionized.
Based on your presentation, it sounds like the field is wide open and it's almost limitless, the questions that we could ask in research about what works best for pain management, especially long-term pain management. Are there different non-pharmacologic approaches in combination with each other that seem to work best? Is there always going to be a drug or pharmaceutical component to treatment? So I wonder what your thoughts are about what kind of research could help create a climate that would help shift us away from relying so much on opioids for pain management.
So the research agenda right now is to non-opioidic pain treatments. Which are the right ones for which conditions? Is there a value to combine therapy versus some of the therapies? First you do acupuncture, then it's almost limitless the number of different kind of questions one could ask related to these various therapies. There still are emerging research related to therapy. There's emerging research related to cannabis, related to for the treatment of chronic pain. So I don't want to completely share on medications and their possibilities, but I am a little bit skeptical that medications will ever play, at least the way we understand medications, that you give systemically for the entire body could ever have a effect, a good long-term benefit compared to non-logic and lifestyle changes.
We've reached the end of our time with you, unfortunately, but thank you very much, Will, Dr. Becker, for spending time speaking to us about pain management. It's a very interesting, important, controversial topic. And we also would like to thank all of the patient participants who attended this webinar, and we look forward to conducting webinars on this topic and other topics in the coming months. So stay tuned. And again, thanks very much to our guest speaker this evening.